Welcome to the Rhode Island DD Community Quarterly Forum, Thursday, July 1, 2021. Hosted by Advocates in Action Rhode Island. Nothing about us without us.
Welcome everybody to the quarterly DD Community Forum. We are so pleased that you can all be here. We have a big turnout. Over 100 people have registered, so we have a big crowd here today. And I am going to hand it over to Kevin Savage so he can kind of kick us off. Kevin?
So much, Michelle. I am going to echo what Michelle said. I'm thrilled with the attendance at the beginning of vacation season and coming off this heat wave. I've never been happier to see rain after these extremely hot days. It's nice to see that it's cooling off, but thank you so much for attending. And as always, just sharing your perspectives. The main thing we want to do today is hear from you. So we have a moderately lengthy agenda, but we will move through it quickly so that we can get to the really important part of answering your questions and hearing your perspective. The first thing I want to do is introduce the new director of the division of the Department of BHDDH, Director Richard Charest. But before I do that, I really wanted to take an opportunity to thank the EOHHS Secretary, Wamazetta Jones, who stepped in the interim between directors to really do a fabulous job on double duty, both as secretary and acting director, to keep this whole system moving forward, evaluating everything that she needs to look at. I'm sure you've been reading the news. There's a lot going on. And but she really focused on helping us be attentive to a number of issues for BHDDH and for our sake, for the Division of Developmental Disabilities. And on behalf of the entire community, I want to thank her for her efforts over the past couple of months. That being said, it's hard to believe that it's been a month since Director Charest was confirmed. It's fair to say that he's moving with lightning speed and tackling the issues of the department. Due to the demands on his time, he's not going to be able to stay for the entire forum. But again, if you've been following the news, you know he's been very busy since he started. But he didn't want to miss the opportunity to make some opening remarks and let you know that he appreciates this extremely committed DD community. So it's with pleasure that I introduce to you BHDDH Director Richard Charest.
Hi, good afternoon, and thank you, Kevin, for that kind introduction. I appreciate the invitation to introduce myself, and I'm pleased to welcome our DD community today. As Kevin mentioned, unfortunately, I can't stay for the entire meeting, but I wanted to take a moment to thank those we serve and who depend on us. It's truly a privilege to serve you. I also want to thank the communities we work with, families, employers, committed providers, and support professionals. I especially want to recognize the input of adults with disabilities into the decision-making process, as their insight is invaluable in assisting us all to achieve the system reform in a manner that actually meets the needs of the population. We honor your partnership, and we thank you for your assistance in placing great value on the abilities and the potential of all individuals, and for creating meaningful opportunities for all. I also want to thank the leadership of Governor Daniel McKee, Secretary Wamazetta Jones, Court Monitor Anthony Antosh, and Consent Decree Coordinator Ariana Husky. They have all worked tirelessly with ongoing support and resources to move Rhode Island forward, so we'll be in a place of opportunity for everyone with differing abilities and their families. Kevin has been educating me on how much work has been done with the Division of Developmental Disabilities, and it's impressive. But we have further to go, and we cannot do it without you. We need to ensure that everyone has the opportunity to live, work, and spend time in the community alongside people who do not have a disability. It means having a good job at a good wage, and most importantly, it includes the opportunity to make choices and plan services around individualized interests, desires, and needs. We need to make sure that you receive the best possible services and assistance from us So we need your voice to be here to do that. Please reach out to me or Kevin when you need to. Together we can work to make our system much more robust and person-centered. Thank you.
Thank you, Director. We appreciate your comments. We know that you're not able to stay with us today, but I really appreciate you taking time out of your schedule to join us for a short amount of time.
Thank you
Thank
very much.
So I wanted to move to some updates within DD, and just to keep people abreast of where we are. There's certainly a lot going on. We just got through the budget season. We'll address that in a little bit. But I wanted to ask Heather to talk just very briefly about where we are on the enhanced stipend for SLA providers.
So we just wanted to let everybody know that the enhanced stipend has been extended. It was set to end in June, on June 30th, but we have extended it now from July through December. So the SLA providers, I'm sure, will be, if they haven't already, reached out to the SLA contractors and individuals receiving SLA services to see if they want to remain in the program. I also know that some people who were in the program and then went back to day programming have, some people have chosen to go back into the enhanced stipend, and they can do that too. So we just wanted to let everybody know that that was extended. Thanks, Kevin.
There's been a lot of questions about where we are on day and community-based services for families. And I'll talk a little bit about that now. We're certainly working on that. We recognize that staff shortages are a significant issue, and reopening day and community is a high priority for the department, for our providers, and particularly for adults with disabilities who want to access them, and family members who want their loved ones to be able to access those. And so that really ties significantly into budget initiatives, to the consent decree update that I'll be giving in a little bit. But it appears that we're making little progress, but really the workforce stabilization has so much to do with so many of the initiatives that we've been working on. The budget initiative has, the budget has passed, of course. And so we'll talk about that as we go forward. But what we're going to tackle quickly in this next fiscal year is how we're really going to engage in the transformation of the system going forward to try to affect really significant and long-term change in terms of stabilizing the workforce, increasing reimbursement or pay for DSPs, both in provider agencies and for self-directing DSPs, and in making sure that the community services in particular are available to adults with disabilities who are accessing them. I wish I could tell you that next month is going to be in place, but we're working toward that. It's a huge lift. Obviously, the pandemic was a huge setback in some ways, but also helped us to target that building community-based, person-centered programming is how we need to move forward. And that's really where our initiative and transformation is going to be focused. We did issue in April guidelines, and we can reissue new guidelines if we need better clarification on visitation, so that visitation should be occurring. I believe it is occurring. If there are problems with that, we can work to amend that. But we want to make sure that visitation isn't difficult for residents to the degree that it's able to occur in a healthy and safe way, but largely with nearly all, particularly in residential community, nearly all of the residents, not all, there are some health reasons for not everybody, but nearly all residents of residential facilities were vaccinated, so that there's sufficient vaccination in the residential community. So that was a major success. We certainly give applause to Tina Spears and the people of CPNRI who oversaw the vaccination process. It was a massive success. They worked with the Rhode Island Department of Health, certainly with BHDDH, and helped people across not only the residential system or their provider agencies, but the entire DD community in facilitating the vaccination process. And that has made visitation safer for everybody. So we're excited about that. There's significant vaccination among the staff community. We're working on getting the actual numbers with that. Brenda Duhamel and Ann Leclerc are working with our data team, Marilyn Goudreau, who's the person at BHDDH in the data unit who's assigned to help us with obtaining data, is working very diligently with Rhode Island Department of Health to get some final numbers out on who's been impacted by the pandemic, actually who's gotten COVID, who's been, and so we want to get those numbers out so we have a better understanding of who's been impacted. She's working on that. And then what the actual vaccination numbers are, so that we'll know that and just have better data on that. But I think what we're going to see, and I'm excited about this, is that the vaccination numbers will track significantly higher than the general population. And I think that's a major achievement. So I think it's too soon to claim that, but I think we're going to see some really remarkable numbers in the DD community in vaccinations compared to the rest of the community. So I think we'll wait on that, but those numbers are being put together. So we know what the numbers are in the residential community, but we need to get the numbers for the wider DD population. Consent decree, as many of you know, we worked beginning in July of, there was a court order in July of 2020 requiring the department to address administrative barriers that impacted the provider system, which also then impacted adults with disabilities, and being able to access services or diverted resources to deal with administrative issues that diverted resources away from providing services to adults with disabilities. And there were 16 items identified in the court order that needed to be addressed. We broke these 16 items into 5 categories and developed work groups that included members of the state team in several departments under the EOHHS banner, and also worked with members of the provider community, stakeholders that included advocates, family members, and adults with disabilities to come together to figure out what we needed to propose as solutions to overcoming those barriers. Some were short-term, some were longer-term. I just need to fix my computer because I know you can see me, but I can't see any of you right now. And the goal of doing that was to reduce the administrative barriers so that the resources that were dedicated to that could be redirected back toward providing services directly to adults with disabilities. The work plan has been developed and was submitted to the court yesterday on time, which you can't not submit court orders on time, but I'm so excited to say that it was submitted very thoughtfully on time. It included and was built, included all stakeholder input and was built from the ground up, which is really how I love to do things. And people who have worked with me in other parts of my work in the department know that I do like to do that. It's not the easiest way to do things, but it's the right way to do things. And we get outcomes when we work from the bottom up with our stakeholder partners that's meaningful because we all buy into it and we know that it's what the community wants. It's what meets the needs of adults with disabilities, and we're satisfied with the results. It's also when we start to see that things aren't working and we can come together and adjust them together. Sometimes everybody thinks something's going to work and it doesn't. but then we own it together and we fix it together. So I'm really excited about that. I'm excited that we're able to get the work plan in place. It will become public very soon. And I really want to thank all of the people who were involved in helping us get there. And there were a lot of people. It was not just a few people who were doing that, but a lot of people got together on a regular basis and put a lot of time and effort into developing the work plan. And I just really want to take time to thank the team leaders. By the way, each team was led by a member of the state and a member of the stakeholder community. So this was really an enormous effort. And I just can't thank people enough. I also want to talk about how we're going to move forward. The work groups will continue because what we need to do from here is take that work plan development so that we implement all of the items in the work plan to make sure that they're achieved. Some actually have already been achieved. One of the biggest issues that came both from the provider and stakeholder community was annual authorization so that services weren't interrupted when they needed to be approved every quarter. That has been accomplished and we're very excited about that. A number of other issues are on the verge of being implemented, and those have to do with providing support and training for the CIS, for example. We're very close to getting that done, and getting better communications out in different languages and communication styles. So we're working really hard to kind of get the things that we can check off quickly, but I think will meet a lot of needs in the short term very, very quickly. The longer term issues have to do with fiscal reforms that will make things easier for people to understand and get information to consumers or adults more quickly. For example, you'll know where you are in your budget, how much you've spent in your authorizations on a regular basis, likely a quarterly basis. What have you spent and how much do you have left? And then the other fiscal reforms will take 1 to 2 years to get implemented. But change doesn't happen easily in any large organization, not just government, but any large organization. But we're going to keep working on it until we get through the entire work plan. And I'm going to go through the entire presentation so that we'll just spend the rest of the time on questions, if that works for everybody. The one thing I will ask on the people who are on the talking points on the state team is if you think, I'm going to move off the consent decree. If you think I left something off in the consent decree, you guys can feel free to speak up. On the budget, one of the key factors in increasing recruitment for and stabilizing the DSP workforce was increasing the rate, the wage. The way to do that is the state doesn't set wages, it sets Medicaid rates. The rates then translate into providers being able to increase what they can spend on wages. So there's a formula, it's complicated, I won't get into the details, but there's a formula that is implemented to, if the state sets this X rate, it can translate into a particular average wage, base wage. So that the rates were set so that providers could set an average wage of $15.75, which was a nearly 20, I think 19% increase in base wage just this year. The requirement from the court is that we get from where we are now to $20 an hour by fiscal year 2024. And so we're on track to do that. That is our requirement. That's what we're working toward. So from $15.75 in what is now fiscal year 2022, which started today, to get to $20 an hour in fiscal year 2024, which starts 2 years from today. So I think those are the key things that I think that people really wanted to hear about regarding the budget. If people have other questions, I'm certainly happy to entertain those. Tracy Cunningham is going to talk to you about work in the area of adult employment. Tracy?
Thanks, Kevin. Hi, everybody. Just a quick update. I wanted to just let everybody know that the PSET project is still underway and has been extended for one more year. There's about 54 individuals that are in that program currently. And to date, we have 6 individuals who have secured employment and 1 individual who is in a new internship. So that's exciting news. I also wanted to tell you that we ran a report today to see how many individuals since January, the first half of the year, have secured employment. And this is based on what we have through our TheraP system that many of you have heard about. So 47 individuals have secured new jobs. And to date, in 6 months, 2 individuals have lost those jobs. So we have 45 people with new jobs that are remaining. And that's with the support and services of 14 providers. The average, I didn't do average hours. We looked at the hours that individuals are working, and it ranges from 2.5 to 20. And from minimum wage to up to $18 per hour. So we've got a lot of variety, and it's in every industry as well. We wanted to let you know that individuals who are looking for employment and are ready to get back out there, that we do have employment providers, and some of your providers are ready to start getting out there and looking for work. And we know many individuals are ready to get back out with the reopening. So feel free to reach out to myself or Jane McKay, who's here also, if you have any questions about getting into the workforce and need some support with that. I'll put our email and phone number into the chat so you can have that. And certainly willing to take any questions. Just a short update for today.
Thanks, Tracy. Next, Brenda Duhamel is going to talk about one of my favorite subjects, conflict-free case management.
Thanks, Kevin. Good afternoon, everyone. So yeah, I'll give you a brief update on conflict-free case management and the progress that we've made so far. So there was a large stakeholder work group that put together a model of conflict-free case management, the way they believe it will work and make sense in Rhode Island for adults with developmental disabilities. We presented that to EOHHS, to the Long-Term Services and Supports Redesign team, who will be working to take our model and create an aligned model for elders and adults with disabilities for the remainder of the LTSS population. The team is working together to do that alignment and to figure out where we may need some technical assistance or some additional expertise to sort of move forward. And we are hoping that by the end of August, we have a plan that we can share on how we intend to move forward with the roadmap towards implementation.
Okay, thanks, Brenda. And lastly, Sue Hayward is going to talk about transition to adult services.
Good afternoon, everyone. Very happy to be here to give an update in regard to transition. We continue to work very closely with Department of Education, Office of Rehabilitative Services, Rhode Island Parent Information Network, and our adult service providers to improve transition services for youth. Every year, DDD, Rhode, ORS, and RIPEN work together on a collaborative state plan, which guides our collective work throughout the year, and several cooperative projects are underway. RIDE, DDD, ORS representatives from some school districts and several adult provider agencies have created a transition work group focusing on the last 2 years before school exit. We're working on improving communication and understanding about transition services provided through school-funded supports, adult service providers, and local community resources. The focus is very much on whole life planning and person-centered supports. And we're having in-depth conversations about what is working, where challenges exist. And we've also developed action steps addressing ways in which we can more effectively partner in providing transition services. Also, a transition community of practice has been formed with representatives from adult provider agencies, meeting quarterly with the DDD transition administrator with the goal of ensuring consistent and timely communication and discussing challenges and sharing resources. Several members of that group also participate in the work underway with the transition work group. One of the action steps resulting from this transition community of practice was in partnership with Rhode to hold 12 provider chats, which were opportunities for adult service providers to communicate directly with educators through facilitated conversations, to understand from each perspective how transition is approached and how communication and supports can best take place when working with a student. So these provider chats led to very open and meaningful conversations, and we're working to expand those chats to students and families this coming year. I do want to mention too that Rhode has been very generous with their resources with the Transition Community of Practice Group, opening many of their trainings to adult service provider staff. For example, their trainings on virtual job shadowing, community mapping, and post-secondary education options. And we've been very, very grateful for those opportunities. Through our work with RIPEN, 4 webinars were developed this year: a peer-to-peer webinar with young adults having real conversations about employment, another peer-to-peer webinar for parents discussing employment, a 3rd webinar focusing specifically on customized employment, and a 4th webinar, which is an introduction in Spanish to the application and services provided through Division of Developmental Disabilities. These webinars are all available on the RIPEN website, and I really encourage people to view that website as there is a wealth of great information for families. We're continuing a social caseworker assignment by age 20 or 1 year prior to school exit for eligible youth. And this gives 1 to 2 years for social caseworkers to support students and work with the IEP team as the student prepares to exit school-funded services and move into the adult world. Recently, a guide was created for social caseworkers based on feedback and vetting from educators and families as to how social caseworkers can most effectively participate as part of an IEP team. Resources and information regarding community services are continually shared with social workers as they assist people to build a network of supports as part of a whole life plan. Some of those resources include information about smart home technology, community resources for reduced cost medical equipment, groceries, housing options, summer learning opportunities or tutoring, and opportunities to build social connections. We're always interested in feedback about what is needed and how to most effectively provide transition services. So I will put my email in the chat for anyone who would like to communicate with me directly.
Thank you, Sue. That actually concludes the state's presentation today. We are going to watch a video from the Rhode Island Department of Health, which I hope someone else can introduce. I don't know what it's about. I forgot. Someone told me, and I will just.
I can introduce it. It's from the conference
Awesome.
last year. And we asked Dr.
you.
Ann LeClaire helped us make this happen. Yay, Ann. We had our statewide conference last week, and we asked the Department of Health to give updates just about the COVID, what's going on with the whole situation. And Dr. McDonald was wonderful to do this. He gave us recorded a message, and we actually took it, and we had ASL interpreters at the conference. So this version, he recorded a message for us. But we took it and put the ASL over it. So I'm going to share my screen and you can see it.
I'm Dr. Jim McDonald, Medical Director of the Rhode Island Department of Health, and thank you for letting me be part of your experience today. So, one of the things I reflect back on the pandemic in Rhode Island is, our first case was February 28, 2020, about 16 months ago. One of the big messages we kept telling people in the beginning when we started shutting down our economy was we really need to wait till we have a treatment or a vaccine, but we really need to do what we can to minimize people's exposure. Well, we gave the first dose of vaccine in Rhode Island on December 14th, 2020, a little under 10 months into the pandemic in Rhode Island. So that was a big win. But even before that, we had monoclonal antibodies to treat COVID-19. Since December 14th, over 70% of the state is in a good place, is getting at least 1 dose of vaccine. And we're really heading in the right direction as far as hospitalizations, deaths, and really just people having cases. So we're really moving in a positive direction. That didn't happen by accident. It happened with everybody in the state pulling together, doing the right thing. It's funny though, there is some things that we need to know now. And I feel like sometimes when we talk about the pandemic, people are like, well, I've heard that story before. Because you remember in the beginning, back before the pandemic came to Rhode Island, they talked about a virus in the Far East, and I don't know if you paid much attention to it. A lot of us didn't really, but then it came, and then it's like this scary virus no one has any immunity to. And I feel like a lot of times we keep telling you that's what's happening. There's a scary virus coming, and we don't have immunity to it. And when we hear about the variants of concern, I'm afraid that's what people are hearing, and that's really not what's going on. The variants of concern are viruses related to the SARS-CoV-2 virus, or just genetic mutations from that. However, they're still covered by the vaccine. And I think that's just an important point to remember. Variants of concern are still addressed by our vaccine. It's still covered by the monoclonal antibody, the Regeneron product that we have to offer there. So that's the threat right now. Now, you hear a lot about the Delta variant. Right now, the Delta variant is about 10% of cases in the United States. We're still seeing it in Rhode Island. We think we have a little more than a handful of cases right now, but it always lags, so we know it's here. Why the Delta variant became a concern, though, is because what we noticed from the United Kingdom was it's more likely to spread from one person to the other. So it's more contagious. It looks too like it causes as severe disease, or maybe a little bit more severe disease than what we see with the original SARS-CoV-2, which a lot of times just call that the wild type. So I just think it's important to understand that when we talk about the variant, we call it the Delta variant. Now, I think some people are like, why do they keep changing names of this virus, right? In the beginning, it was called novel coronavirus, and they called it SARS-CoV-2. Then we talked about the B117, the P1, the B1351. Well, why are we calling it the Delta? So the World Health Organization decided, without asking me, mind you, that all these viruses that are variants would be called letters from the Greek alphabet. Now, I don't know why they chose the Greek alphabet, because quite frankly, unless you know Greek, you don't really know the Greek alphabet. I had to look it up, right? If it was up to me, I would have gone with A, B, C, D and told everybody in their language, you can pick whatever your A, B, C, D is. But that's not what they did. So there was an alpha, there's a beta, there's a gamma, now there's a delta. Those are variants of concern. If it's a variant of concern, that means it's more transmissible than the wild type and may cause more severe disease. There are other variants of interest, which are still something we know about, but they're not as transmissible. Now, in case you're curious, those are named all the way up to the Greek letter of lambda, which goes up to the letter L. So there we go. Not super worried about those because they're not a variant of concern. So I'm not worried about variants of interest right now. I think it's important to just have context about this whole thing. And I guess one of the things I'll just throw here with is like, I think sometimes when we hear the same story over and over again, we kind of just tune out a little bit. But I would suggest that's not always the way we do things. So a lot of us remember the movie Jurassic Park. There's my dinosaur here, right? I'm showing you dinosaurs right now because why not, right? If you guys think about every Jurassic Park movie, isn't it really the same movie? People are actually surprised they could find dinosaurs. People surprised that the dinosaurs get out and ate people. Then people surprised they actually should leave the dinosaurs alone, right? Every Jurassic Park movie is the same. They still make over $1 billion a movie, and there's another one coming out next year. Maybe we'll see in theaters, right? My point is, we don't get tired of Jurassic Park. Why are we getting tired of the pandemic? Well, because the pandemic hits us every day. It's caused us pain every day. And we've all gone through a little bit of trauma because of the pandemic every day. No, I can't take away the pain or the trauma. All I can do is explain what's going on here. We're in a difficult time, though. I think those people who are in the behavioral health industry in particular, it's like, yeah, it's a very difficult time. I, as a pediatrician, prescribed a lot more Lexapro last year than I did amoxicillin. The anxiety is affecting our children, affecting all of us. I think we all need to do our part to mitigate the impact of the pandemic. If there's one thing you can do, if you haven't gotten a vaccine, I would just say, I'm not sure what your question is. I'd be happy to answer it for you. But if you have not gotten a vaccine yet, let's go ahead and get that done, all right? Because it's a safe vaccine. You know, well over 150 million people have gotten the vaccine. Over 2 billion have got it in the world. It's good enough for them. It's good enough for you. Let's go ahead and get that done. I think another thing you can do is, you know, let's just think about how we can be a positive impact for others around us. When you think about going through a population stress and a population trauma like we've done, I think those of us in the behavioral health industry know there's a lot to be said for just letting people decompress from that trauma, let people have the space they need where they can. I hope you'll do what you can today to make people feel a little more relaxed, a little more informed, and really understand the context of the pandemic a little bit better. Hey, where are we now in the pandemic? We have a completely preventable disease. We have a treatable disease. We're heading in the right direction. And I really thank you guys for letting me be part of your conference today. Hope you have a good rest of the day. Thank you. I'm Dr. Jim McDonald, Medical Director of the Rhode Island Department of Health.
You're muted,
Deb.
Deb.
If I had 25 cents for every time I was muted, and somebody did that, I could pay, buy us all new cars or something. I was just apologizing for the technical glitches there. You can watch the entire recording on our website, like I said, and it was Dr. Mc, that was very right to the point for us. We really appreciate it.
I didn't know what to expect, but I thought that was excellent. And this was a good opportunity to show that. So
yeah,
thank you for suggesting that, Deb. That was excellent.
Anne suggested it. Thank you, Anne.
Oh, Anne. Oh, that's right. Anne. Well, thank you, Anne.
I also want to thank Christine Iman for helping us get that from the Department of Health.
Yeah, that's great.
It was
Thanks.
wonderful. It was a good team effort.
Okay, so we have 45 minutes. That's great. Question and answer time for the community. And I think there are 81 participants. That's great. So
Can I, before we start that, yes, we're recording it. Yes, you'll be able to see all of it afterwards. So if people ask that in the chat, it's being recorded and you'll be able to watch it afterwards.
let me ask you this, Deb. How are we going to manage the question and answer time so that everyone's not talking at once?
If people have a question, actually we can turn it to gallery view because people have been putting them in the box. But if people wanted to ask their questions out loud,
Oh, okay.
you know, that would be
Well,
great.
if we're putting them in the box, I just want to know how I'm going to answer one at a time.
I will, if they're in the box, I'll read them to you. I'll make sure that we didn't miss them.
Why don't you do that?
But if people wanted to actually ask the questions too, we could do that either way right now. And Kelly Donovan's watching chat for us too. Right now in the question and answers, there's one question that says, there was an item on the agenda for self-directed support changes. What are those changes? I don't recall any being mentioned.
Right now, I don't think since the last meeting, unless someone on my team wants to correct me, that the only real self-direct change, which I mentioned, was that the DSP rate change, which impacts wages, also will impact direct support DSP wages. So that impacts the entire DSP community, not just in provider agencies, but for wages that can be paid to DSP staff. We will come up with clarification that when the wages, the rates are intended to increase wages, it's not intended to be used in any other way. So we'll have clarifying language that goes out requiring that even for self-directing, and this will go to provider agencies as well, the rate increase needs to be used for wages. That will apply both to provider agencies and the DSP community.
I was wondering if there's any updated guidance on restrictions at day programs, indoor capacity, screenings, etc.
I did make the point that we haven't issued new guidance since April, but we will, if people need new guidance, we will issue that in accordance with what is the CDC guidelines. So if we need to, we'll do that. We'll talk to the providers on what they need, but we'll get on that in July. There is a lot of guidance that's come out through CDC. There's also, we're opening up. So I just want to be clear that we'll look at that from a number of perspectives on who the population is using a particular facility. We'll look at what businesses are doing and what the flexibility is by business and what we want to do by regulation. So we'll take a lot of factors and we'll work directly with the people being impacted. So we'll work with the providers on that and we'll do it together.
The follow-up to that was they just said that would be great, especially for day programs. When will social workers return to attending person-centered planning meetings in person?
Workers are being called back to work on July 19th. So everyone's expected to be back on site and will begin resuming a normal business schedule on July 19th.
Somebody wants you to explain what a tier is.
So a tier is, there are 4 tiers. We call them A, B, C, and D. We should maybe call them alpha, beta, gamma, and delta. I don't know, but we use those that designation. And when an adult with disabilities comes into the system, we perform an evaluation or an assessment, I should say, not an evaluation, an assessment that determines what their needs are. And we're actually going to, well, let me just say what we do now before I complicate it. And that assessment determines, that needs assessment determines what service level the person arrives at. And the service level is identified as a tier, which identifies their general funding. And tier A is the lowest level, tier D is the high, no, tier E, actually, it's 5
Tier
levels.
E,
Tier E,
yes.
B, C, D, and E. Poor Heather was like ready to scream. He's got it wrong already. I'd be
Sit
lost
down.
without her, I'll be honest. It's 5 levels, not 4. Epsilon. 5 levels. So tier E is the highest, and that begins the process of establishing the financial package for the individual. That's the basic explanation of a tier. It gets broader than that, but that's the basic level.
So people are starting to put a lot of questions in the chat rather than in the questions and answers. Just if you could put them in the questions and answers so we could find them. But in the meantime, the ones that came out of the chat, one which came out while you were talking about this, so I'm not sure if it overlapped, but they said self-direct changes was on the agenda. What information are you providing? I think, I'm not sure if that's the same question.
It's really all, I don't have a lot on self-direct,
Okay.
so that's it.
Another person said it might be helpful to explain what PSEP, what that stands for, and just share a little bit more about PSEP.
Sure. So PSEP is an acronym for a very long title, Person-Centered Supported Employment Performance Program. It's 3 because this is the 3rd iteration of it in the last just about 4 years. It's a project and program that there are 4 providers, lead providers with a collection of partners doing customized employment. On our website, we have the flyers for each of those different projects. So we welcome you to go check out our new website, and you can find it there under employment. Happy to have any questions, specific to your needs about that, at an email or a phone call. But really, it's for individuals who have really never had a work experience before, who are looking to go to work, and they'll be working with the providers in this project through a discovery process, which is really getting to know who you are, what kind of work you're looking for, what kind of skills you have, and what really is going to be the best place for you to work. And then a combination of discussions with employers and yourself and your team to match all of that together. So you'll have a great employment outcome.
Will the recommendations to the court from the administration working groups include Medicaid waiver changes? If so, will access to technology and billing remote services be preserved?
What I'll do, as I said, is I'll get out the work plan to the stakeholder community so that everybody can see the details on that. And then we can maybe set aside in the next quarterly meeting going through the work plan, which I think might be beneficial since we don't have it in front of us today. Why don't we defer the work plan questions to, let's go through what the work plan is with the entire community at the next meeting, and we can go through the details of that. It just got submitted yesterday, but I think that it would be a great opportunity for the entire stakeholder community to actually see the work plan and then for us to go through it at a meeting. But I can tell you this generally in terms of answering. I'm not trying to deflect the question in any way, but increasing technology is part of the department's 3-year plan that we'll be working on with the stakeholder community going forward. So there's no effort to pull back on technology. The goal is to move forward on increasing technology. So if that's part of what that question is, preserving isn't what we want to do, growing is what we want to do, if that's helpful.
Will families as paid caregivers under self-directed supports be extended permanently?
That is a proposal that we are absolutely working on. I will add to that, though, that families who are paid caregivers will be required to meet the employment guidelines that any caregiver would be required to meet. So if you're going to be a family member who's providing day services going forward, it will also mean that you would be required to meet the support services to help your adult family member access day and employment services like anyone else in accordance with the requirements of the consent decree.
There are major capacity issues in all programs, but especially within residential programs. Is there an identified residential director within Rhode? What specifically is being done to address anyone on the critical care list, especially for those youth under the care of DCYF who will be moving into BHDDH?
The first thing I would just like to say is capacity, especially in residential care. There is staffing in day programming. I don't know that I want to use the term especially, but I just want to point out that we haven't gotten day programming up and running, so I don't know that it's fair to say that it's especially in residential. So I just want to point that out. If I let that go and you're one of the families not being able to access day programming, I don't know that people would agree that the issue is especially residential. So I'm just not agreeing with the premise that it's especially residential. There is a staffing shortage across the entire system. So I would say that it's especially across the system, and I wouldn't limit it to or focus particularly on residential. But day programming for some people is as important as residential is for others. So I want to just make the point that it's across the entire system and just not agree with the premise, that's all.
Kevin, just so you know, somebody followed up and said, about that capacity in the sense that there are no beds for people to move into. It's part of that.
Oh, okay, thank you. I was thinking you meant in terms of staffing. So yes, capacity is a huge issue. Thank you for the clarification. Capacity in residential care, particularly in terms of that critical care list is, and anyone on my team can back me up on this, huge concern of mine. I have been involved in meetings with some of the people on the DCYF side, private providers and DCYF, that this is an issue that I want to resolve. I am, so I'll use the term especially concerned that we have people backed up in DCYF programs in DCYF or Bradley Hospital that we can look at as in safe placements, but my concern about that is twofold. One, it's not the right placement for adults who are ready to go into adult programming to linger in youth programs. Two, it's wrong for the DCYF side because there are youth waiting to get into beds that they're being denied, often lingering in hospitals because they can't get in the beds reserved for them. So it really creates a moral problem on both ends. And so we've resolved a number of those issues, but there's also an issue on the critical care list of adults at home whose families are no longer able to provide adequate care, who need them to get into homes, and we need to make those available. I don't know where we are on this. I did put in a request for additional funding in the Rescue Act. There's a lot of issues in getting funding for that. I'm not promising anything on that. It's not my ability to promise anything on that, but I put in a request that we get funding to help to address this issue. But there's a lot of requests that far exceed what money is coming in on that. But I would like to see us be able to this year resolve the critical care, the critical needs list. But my primary issue is that when you're ready to transition out of a DCYF facility or a hospital, that you're not tying up hospital beds that other people need, DCYF beds that other children need, or that when a family is not any longer able to provide for the care of an adult, that we have the capacity to deal with that in our system. So those are the three areas that I want to work extremely hard on this year to address. Because when one area is backed up, it has a domino effect on other areas, and we know that to be true. So we're working hard on that.
I believe there was an agenda item for housing, but was not discussed.
I'm sure there is, and I'm sure someone sees it. I
Okay.
don't have anything to add on housing. If anyone on my team does, I'm happy to have them talk about it.
I would just add, Kevin, that we do have a new residential coordinator.
Oh, yes, I did want to talk about that.
So
Go
do you
ahead.
want to introduce her?
Yeah. No, you can.
So we do have a new residential coordinator who I believe started in the beginning of June. I think, I don't know remember the exact date, but her name is Melissa Greenleaf.
She's on the call, right?
She is, because she did, no, I'm not seeing her now. I'm going to say she used my link, so that's why she ended up on here, but I think she might have found her link and went in that way. So I don't think she's not on the panel anymore. She was earlier, but
We can make her a panelist if I find her.
we do have a
Find her, I'd like to
residential
introduce her. That'd be
coordinator.
great.
Yes. And we are very excited about that.
Melissa is logged in as Tracy Levesque.
Hello, hi.
We would just introduce.
I know I should change the name. I'm not Tracy Levesque, I'm Melissa Greenleaf, so I'm the new residential coordinator. I am very excited to start and do my best. I do have to say, I've worked at Eleanor Slater for a very long time, so I've gotten to work with some really vulnerable populations. And coming into DD, I kind of always knew that there was struggles, but now that I've had the opportunity to work in the department, I've gotten to see them firsthand, and I see the challenges that we face, and I know that we are all very committed to doing the best that we can to improve the system overall. Because I see it myself and it's heartbreaking. And I know that there are wonderful people in the department that are wonderful to work with. And I know that everybody is so committed to making positive changes moving forward. So I'm very excited to start this journey, and I look forward to hearing from anybody that has any questions. As I learn, I have a lot, I'm still training, but I'm very excited. Thank you very much.
And we're very
All right.
happy to have you too.
Who will be responsible for overseeing monitoring support services for people who self-direct their services?
That actually comes under the case management part of the department, and that is under Brenda Duham.
Many of the youth from DCYF aging into our system and who need residential supports require more and intense services. Is the division willing to address need for increased funding that does not require jumping through multiple hoops and constant requests?
Yeah, so I think when I talked about the administrative barriers, though that work group really is working on all areas of making people, so the jumping through hoops speaks loudly of administrative barriers, making it too hard for people to access or understand their services. That's exactly what the groups are working on. Why is it so hard for people to figure things out? And that's what the whole administrative work group process was working on. It shouldn't be that hard, and we're working on it. Sue Hayward oversees the transition part and constantly works on addressing those issues, but the administrative work groups, and Sue is part of that team, is working to simplify the process so that resources aren't diverted from providing services in order to deal with administrative issues, but to actually provide the services directly to you. So yes, we're working on that. It should be easier. I know a lot of effort goes into that. It's interesting just in terms of how systems work. It's really important every time a new process is developed, as you listen to who thinks they need things, if you listen to, you have to make sure that it's consumer focused. A lot of people will tell you what they need, but this court order has been a godsend in many ways, because you have to filter things through, whoa, you're adding a lot of burdens to adults with disabilities, to their families, and to providers. We're under a court order not to do that. So I think that's extremely important, that not only do we get through this work group process, but that as we add new services or items or programs, we don't add them with, in order to do that, you have to do these new 15 things.
And Key had a comment for you, Kevin. He wanted to say, thanks, Kevin. As there was a lot of progress in the area of technology, pleased to hear that we will not only be able to expect a continuation, but a growth. An info session on the work plan would be awesome. Credit to Heather's efforts as well in gathering consensus to that need.
Great, thanks, Key.
A follow-up question, I don't expect that in 3 to 6 months, the need goes away and that the individual no longer needs enhanced supports. That was from Linda Ward.
I hope I didn't communicate that I thought anything would go away in 3 to 6 months. Linda's probably making an extremely good point that we're missing. So if we could get her on the line,
that was really related to, you know, the enhanced supports. And as Tracy Levesque knows, because I've worked with her on moving a couple of folks out of Slater over the, more than a couple, but in the last couple of years, a couple of people. It's just, again, you addressed it a little bit, but I sort of was trying to make the point, somebody who has spent, you know, maybe 10 years in DCF services or 17 years in Reagan 4, in 3 to 6 months, we have not, and no matter how good a job we do, we have not gotten them to the point where they don't need enhanced services. And so Tracy knows this firsthand, and Kevin, you know it because I CC you. Historically, it's been, we have to keep fighting for it all the time, all the time. So just, I guess what I'm saying is, let's think about as you move forward, and you talked about in the administrative group, if we're going to have annualized budgets, then these enhanced services should be annualized, and you should trust that as providers, we're not going to access it if we don't need it. And again, Tracy knows we've had our friend BP, who's doing wonderfully. We had enhanced services. We have only used it a handful of times, and it's there. So, so I don't have to go back and say to Heather or Ann or you, oh my God, we got this bad thing going on. I need to put more staff on. It's there. So moving people from very regulated institutional settings into group homes, which are not congregate care or institutional settings, but they're home, requires a significant change for the individual, and let's not make it hard for us to do that work. That's my point. We do the work. We've been successful. Tracy knows in particular with these two folks, we've been successful, but it was a lot of work and a lot of whining and complaining that I needed the money to do it. So let's just not going forward. That's all.
Yeah. So let me just comment on that, that to move someone from a hospital, and it's hard to do, into a home requires tremendous skill over time. And if it's, people will do it once, but if we don't react correctly and supportively to doing it, they're not going to want to do it a second time.
Exactly.
So to be successful, we really need to get on the same playing field with the provider. If we're successful once and we're supportive in doing it as a team together and recognize from that clinical and administrative and programmatic point of view that this is hard work, and it can be so rewarding when everyone's doing it together. But if you're fighting for it, it's like, yeah, I did it and I was successful, but no one even knows what I went through, and all they did was fight me. You're not going to want to do it again. And I come from residential care. I've said this before, I've never had a harder job. So I greatly appreciate the comment that you made, and I'm so glad that you got on camera and shared that, because to get someone into a residential program, the transition and the trauma for that person, that individual, to move from that, even though we know that institutional care isn't the right setting, it's extremely traumatic to go from that into a community setting. And helping someone through that trauma is one of the most difficult and compassionate and kind things you can do, but it's not easy work. So
yeah,
thanks.
and I just want to add, Kevin, that in both of these recent situations, I can't say enough about the staff at Slater who worked with us on both of these folks. And it took probably, what, Tracy, 6 months for both of them, because there was a lot of visits and a lot of time we spent on AM and in Reagan 4. And that's the other thing you have to realize. We don't get paid for any of that pre-work, and it's okay, but not okay, but we do it. But you want to do it right, and it doesn't happen overnight. So again, Slater staff and the OTs and Tracy and all those folks were great in making it happen. And we did it as a team.
I just want to commend your staff for doing that and making the transition happen, for all that effort. And we don't have an opportunity to thank people enough, but I really do want to thank the staff, the DSPs, the administrators, and all the effort that goes into creating successful transitions. So thank you.
For more employment and community participation, we need more options for transportation. For example, opening the ADA corridor. We need federal support to open the corridor. Can the court help?
I know Ann was working on transportation. Ann, did you have any comments you wanted to make regarding transportation?
For the agency provide transportation, we went by what is required of public transportation, which still requires masks per federal guidance, but no longer has capacity restrictions. But we are also leaving it up to programs to determine what the needs of the individuals they serve are. Are people vaccinated? What else is going on? What other risk factors are there? So that if they need to still have capacity constraints on their vehicles, if they still need to limit the number of people on the vehicles, that would be on a case-by-case basis, the agencies to decide. Small groups in cars who are all vaccinated or are consistent groups, that would again be up to following, I think, the state's general rules around masking. The ADA corridor is set by federal law. So we open up the ADA corridor. That would be more than Rhode Island. That would be the national. So the court, the law, the Americans with Disabilities Act would have to be changed. The state does have the option of doing more than what federal law requires, but RIPTA hasn't been funded in a way that would allow for that. We have contracted with RIPTA to provide some transportation. And again, it comes back to how can we work with them to see if we can open it up. And we've had those conversations. We continue to talk to RIPTA about what they can do and how we can work together. So we're still looking at areas and still talking with RIPTA around that and looking at options. If it can't be RIPTA or the RIDE program, what are other options for people who live outside of the urban areas who might need service? So we keep looking at it, but unfortunately today I don't have a solution for that issue.
If a consumer has had L9 funds renewed for over a year, at what point can the consumer, family, and provider request a tier change consideration? The process to request L9s is time consuming and it has to be repeated throughout the year in some cases. It'd be easier if there was a threshold that would be reached to consider their funding as a whole.
If you're requiring, I would work with, I would call Tracy Levesque and talk about whether there's a need for a tier change. I'm going to just say this on this L9 issue. We are going to work this year on adding to the SIS process, a process to better address funding up front. L9 is an appeal. I don't think people should have to be going through an appeal process to get appropriate funding. So we're really going to address that in this fiscal year to really try to reduce this reliance on L9s and appeals. We're committed to, if you have a service need that needs to be funded, we want to be able to fund it. The mechanism seems to be out of line with what our mission is. And you shouldn't have to be begging for services and going through painful processes to do that. So part of our work plan is to reform that. That's one. If you think you need a tier change and that your tier isn't accurate, you can request a tier change.
Speaking of tiers, there's just a comment for you there, Kevin, that said, thank you, Kevin Savage, for your succinct description of tiers. When I first asked about this many years ago, it was a long-winded definition. You captured it all in 30 seconds. I hope the administrative groups make good use of flowcharts and diagrams as they work towards simplifying processes and definitions.
Thanks.
This is Matt, who's in our class, and he said, can he ask this because he came late? You might have, it's kind of general, but he wants to know if there's anything different with services in the COVID world. Anything?
I would say that's probably enough for today. Can you connect us through email and I'll email?
We can. You talked to him at the leadership class actually too.
Yeah,
Get some
I'll
questions
email
in.
you. Let's give John Souza time.
Okay, all right, let's find him.
So we actually just finished our whole series, our year-long series last night. And I'm going to put it together a kind of a summary report that I'm going to give to Kevin and others. But I just would like to address a couple of things that people have talked about. The first and most important thing is that, as I expected, our residential support tools are relatively limited compared to many other states. And so one of the things that we need to really think about is expanding various kinds of ways of supporting people. We also, I think, need to recognize that some of the ways that we're doing it now could be improved. Lots of people are looking for more options in terms of shared living or life sharing. And I think that that system needs to be looked at to kind of allow more flexibility. In many states now, we're seeing a much more emphasis on individualized and personalized housing. You know, it's like everything else. If you have enough flexibility and enough options, you open up in the high-end intensity need area, especially, more spaces for people who need that level of support. The other thing is that we're going to kind of recognize too is that there are a lot of people whose parents are kind of blindsided by the realities of residential support kind of late in their planning process. It's not until after their kids have gotten out of school that they seriously think about housing. And I think we need to help the systems move that thinking further down. Minimally, you know, when you start talking about transition, there ought to be a lot more discussion beyond, oh, he's going to stay at home for a long time, or don't worry, the division is going to take care of it. Parents need to know that they have a really important role to play in all this, and they need to start thinking about this a lot earlier. I think that the other point that I've learned that we'll share a lot more of is that housing is a problem among all of the people who are poor and needing of support here in Rhode Island. People who have disabilities, people who are elderly, people who are just generally poor and in various social and racial minorities. And they're all being squeezed into more and more high density living arrangements and then more and more segregated arrangements. And we need to turn that process around. It's going to take some work at the legal, legislative level. We can't accept the notion that only certain communities are willing to provide residential options for people who are under-resourced. And so one of the things that I've been working towards helping people recognize is that we need to partner with the housing community in general and work on developing many, many more subsidized housing options. There is, at the department level, Michelle Brophy has been doing a terrific job in trying to bring everybody into this process. And I would recommend strongly that whatever we do, not just be a DD solution. It needs to be a broader housing solution. The state as a whole spends a lot less in supporting poor people in accessing safe and affordable housing than our neighbors around us. The other big message is that until we get better at working at community inclusion, and by that I mean really engaging community and developing support networks among the community, bringing people into their neighborhoods and their local places isn't going to be very easy because these individuals who move into these more inclusive places need more support, and they need it from their neighbors. And so we need to help them earlier on develop social support networks of one kind or another. You know, there are lots of ways of doing that. And that's got to be a very important priority, starting while the kids are still in school. You know, I'm amazed at how often we talk to parents who say, well, yeah, my kid's in regular school and, you know, he or she has some friends, but as soon as they get to be adults, they lose those friends. Well, they can't afford to lose those friends, and we can't afford to let that happen without making an effort to maintain those friendships. Now with technology, with Zoom and all of those other options, it's possible to continue those things. And I'm convinced that you know, we can help maintain that. It's that old saying, right? The only tool you have is a hammer, everything looks like a nail. We've got to have more tools. You know, there are states where the number of people who are living in group living arrangements are very small. They have figured out what to do, and I'll be happy to share some of that information. We're in the process, working actually with Deb, in putting all of that stuff that we've learned into a YouTube presentation, and over the next couple of months, we'll make it available to anybody and everybody who wants to learn from that.
John, can I catch you for a moment while you're talking about housing before we run out of time? Because there's another housing question.
Okay.
Any progress on shared living being expanded to allow people to remain in their own home and have someone move in with them versus requiring the person to move out into someone else's home?
So there's a question that's been asked maybe 100 times.
Yeah.
Let me answer that though.
Yeah. Yeah.
We
Yes,
can
Kevin.
do that.
Yeah.
We can do that.
People can do that.
Yeah, and there's people can do that. There are other ways of doing the way we do shared living that's being done in other states. Like I said, I really believe that we need to look at that more globally.
Cindy Roberts, did that answer your question? Do you want more? That's the person who asked the question about being able to do that.
Call me or Kevin, 785-9541, and we can talk.
She said it answered. Yes, thank you. Okay.
Okay. Thanks for giving me this time. Kevin, I will be sending you kind of a progress report on what we've learned with some concrete suggestions.
Thank you so much for sharing. That was very, very helpful. And thank you for all the work you do on behalf of this community. It's amazing.
Happy to help. Okay, I've got to go. Thanks, Deb. I'll talk to you later.
Right. Okay, thanks.
I do want to just say on the shared living, work with your agencies. We are very happy to be creative on this process. So we've worked with a couple of agencies on creative solutions to make things happen for shared living. It doesn't have to be so formulaic, so we're happy to work on it. Thanks, everybody. So much appreciate getting together with you. It's one of my favorite venues. Any opportunity to get together with families and adults with disabilities and providers, but really this forum just gives such an opportunity to hear from directly affected by services.
Kevin, when you just said speak to your agency, somebody said, which agencies are those?
So why don't we send that out? But because if I list them, I'm going to forget one and it won't be fair.
If a person has shared living, can they also have day supports?
Yes.
Yes. Yes, you can. All right. That's it. It's 4:29.
Okay. Thank you so much.
Thank you. Thank you.
Bye-bye.
Contact Rhode Island DD Services at phone 401-462-3421, email bhddh.askdd@bhddh.ri.gov. View the questions and answers from today's forum. Learn more about the topics discussed and sign up for the DD Updates newsletter at www.bhddh.ri.gov/developmental-disabilities. Watch this recording again at www.advocatesinaction.org/DD Community Forums. Remember, the person in the center is you.